Well, firstly, thank you for the invitation to speak, and I'm really sorry not to be in the room with many of you. I could sort of see the backs of your heads from the from the screen there, and I can recognise some of the backs of those heads. So, yeah, sorry that I'm not there, and it would be really nice to sort of see everyone. And I have to admit that Australia seems a long way away at the moment, probably further with COVID. So I'm going to talk about an ACTnet startup project, and that was called the Australian TB Risk Factor Survey. And that was a short project that was funded a few years ago with seed funding from the CRE. So I just want to acknowledge that funding source. So I don't think I really need to go into much detail in terms of the background, but maybe just in relation to this work, I think the framework and strategic plan for control of TB in Australia does emphasise that, you know, we have vulnerable groups or hard to reach groups in Australia. And of course, we know that the bulk of the notifications in Australia are in people who were born outside of Australia. So as a bit of background to this project, of course, the other thing we know that TB is a notifiable disease in Australia, and it's reported by all jurisdictions, and eventually those surveillance data go to the Commonwealth and into the National Notifiable Diseases Surveillance System, or NNDSS. And of course, in NNDSS, there are a range of risk factor variables collected. I'll show those in a moment as part of routine surveillance. But this list may not include all of risk factors that patients experience or that contribute to either driving the TB burden or to people progressing from TB infection to TB disease. So with this seed funding from the CRE, we undertook what was meant to be a national survey. I'll explain that in a moment. And the aim was to assess risk factors in the Australian TB patient population. And at the top of the slide there, you'll see a paper that was published in 2007 by Al Story and colleagues in London. The paper called TB in London, the Importance of Homelessness, Problem Drug Use and Prison. And in fact, our study in Australia was modelled on this study in London. And I'll talk a bit more about that as we go through. So the aim of the study really was to collect detailed data regarding the risk factor profile and treatment outcomes of a representative sample of patients with TB in Australia. And there were 4 objectives. We had some secondary objectives as well, but the primary objectives were to determine the frequency of risk factors, and they were quite broad. So they were not only clinical risk factors, but also social and behavioural. And the aim was really to inform future surveillance needs. Then we wanted to describe the association between these risk factors and TB treatment outcomes, and I'll explain a bit more about that also as we go through. We wanted to better understand the pathways by which patients present to diagnostic services and any factors contributing to diagnostic delays. And we also wanted to describe how patients are managed and any treatment support strategies that are employed in Australia, including incentives, enablers, and adherence support. And we had some secondary objectives here, but I haven't presented them here. And I guess our hypotheses, I went back and had a look at our initial application, and this is what we put in that application, that our hypotheses were that there would be some important risk factors that are prevalent among Australian TB patients that are not well captured currently by surveillance, and that some TB patients, in particular migrants from high incidence countries, perhaps Indigenous people or other risk groups, would have a range of social, biological risk factors that would be important to further plan evidence-based TB elimination strategies in Australia. And then our third hypothesis was that additional information about the Australian TB population would yield some insights for both policymakers, people who are managing programs, and others working in TB services, and that could help to sort of target interventions for maybe TB prevention, which we've just heard about from Justin, to eliminate TB as a public health problem in Australia. And just to sort of put this work in context, so in terms of the risk factor data that is collected in NNDSS, and as you know, TB is we have enhanced surveillance for TB already in Australia. It's one of a few diseases where we do have enhanced surveillance. But obviously in NNDSS, there are already a range of risk factor variables collected. And you can see in the panel on the left of the slide there, under selected risk factors, these are the risk factor variables that are collected in NNDSS. So we have variables such as whether the person's had close contact, whether they're in a correctional facility, an aged care facility, etc. And of course, there are also other risk factors collected such as HIV status and whether the person is on a health undertaking. And in terms of the methods for this study, it was a cross-sectional survey of TB patients who were on treatment in Australian jurisdictions. And the way we selected patients, I'll try and explain this carefully because it sometimes got a bit confused, but the way we selected patients, we took a day. So let's say the day was 1st of August 2018, and anyone who should have been on treatment or who was on treatment on that day in the jurisdictions became the TB patient sample. So it was sort of a cross-sectional sample. And then for that group, we administered a baseline survey, and that had about 80 questions. And then we did a follow-up survey 12 months later, which had a much shorter set of questions, about 10 questions. And the follow-up survey was really focused on the treatment outcomes and any sort of adverse events, not just adverse events related to medicines, but any adverse events or impact of any social or economic impacts that were experienced by the patient during treatment. So it was meant to capture sort of treatment outcome type data. And we used 2 structured questionnaires to gather these data. They were paper-based, and then we entered them into a database. And the people who completed those questionnaires were either the TB nurses, physicians, or social workers who were responsible for patient management. So this did not involve any interview with the patient at all. Now, in terms of, or maybe I should just go back just quickly, just to explain, this was intended to be an Australia-wide study, but in fact, we collected data in Victoria, South Australia, Northern Territory, and WA. And I'll explain a little bit more about that later in the presentation, but that was really because we had extensive sort of ethical approval processes to go through. And so we ended up collecting a subsample of the Australian TB patient population. And then in terms of our analyses, actually a group of medical students took on this project to analyse the data at Australian National University, and they did descriptive analyses. They did a comparison between our study sample and the Australian TB patient population from 2018 to see if the data were representative. And then they did a logistic regression where they calculated odds ratios and 95% confidence intervals. And they looked at the association between risk factors and delayed treatment completion. And the reason we chose delayed treatment completion rather than just a treatment outcome is that the treatment outcomes were already very high. So we looked at the association between risk factors and delayed treatment completion. Now, as I mentioned, we had ethics approval in the various jurisdictions. We actually needed 7 ethics approvals for the 4 jurisdictions in the end. And we sought a waiver of consent. So that meant that we could collect this information without individual patient consent. And the reason for that is there on the screen that we collected these data under the various public health acts for the purpose of legislated activities under the acts, rather than purely for research. So just in terms of the results, so we collected data based on a sampling date of November 2018 in South Australia, Northern Territory and Victoria, and then a little bit later in WA because of the ethics issues, and I actually moved overseas during that time as well. But we ended up having data from 4 jurisdictions, and we collected baseline data for 402 patients who are here in this table. And then we had follow-up questionnaires for 331 patients, so not for patients in WA. And you can see here the study sample in the first column, and we compared them to TB patients. So the second column is all TB patients in Australia. So we tried to determine if our sample was representative of the Australian TB patient population. And you can see that perhaps broadly it was, except for age, where there were some differences. And so as you've seen, one of the main objectives of the survey was to look at risk factors for TB. So this is a sample of the risk factor data that we collected. And you can see here that known TB contact, and again, this was just filled out by the people working with the patients, not the patients themselves. But known TB contact was the most prominent risk factor at about 19%. Then we had smoking at 14.4%. That's an ever smoker. Healthcare employment, so 12% of patients report some kind of healthcare employment, whether that's healthcare, aged care, and I think we included childcare in that. Diabetes mellitus, 10%, and homelessness, 9%. So they were the main risk factors, although of course there are other risk factors in this table. Notably for HIV status, we have a very small proportion at 2.7%. And then some other risk factors on the table, such as mental illness, people who are on immunosuppressive treatment prior to TB treatment, etc. We also looked, as I mentioned, we did a follow-up survey at 12 months for 331 patients. And here we just asked a fairly simple range of questions. I think, as I mentioned, there are only about 10 questions here. So we tried to collect information on the treatment outcome, whether the treatment had been delayed by at least 1 month, and any adverse economic or social consequences of treatment. And as you can see in this table, so about 1/4 of patients, it was reported that they had treatment completion delayed. So the question was sort of phrased, if the patient was an MDR patient at the start and they should have had 18 months of treatment, and the treatment was prolonged beyond that 18 months. So it wasn't just if the person had MDR detected later, but from the planned treatment duration, was it delayed? So about 1/4 of patients have some kind of delay in the treatment. However, of course, treatment outcomes, as you can see at the top of the table there, are excellent overall. So even if treatment is delayed, the treatment outcomes end up being very, very high. Another thing to note, I think, in this table is that about 12% of patients reported some kind of adverse economic or social consequence associated with their treatment. And you can see there that that was related to employment, social isolation, stigmatization, studies being interrupted, or financial problems. And of course, this was all done pre-COVID. So social isolation might be different now. And then, as I mentioned at the start, we did a logistic regression where we looked at the association between the risk factor variables and delayed treatment completion. And this is part of the table. I've just taken off age and sex here out of this table because it was a very long table. But as you can see in the final regression analyses, there were a couple of factors associated with delayed treatment completion, and this was delayed by at least a month. And the most notable of those were adverse events, high alcohol consumption, and HIV infection. So they were all associated with delayed treatment completion. But as mentioned, when you look at treatment success overall, it's still very, very high. So eventually they completed and most had a successful outcome. So just a few challenges and limitations. So I guess the limitations were that this is a subnational sample. As mentioned, we did intend to do this Australia-wide, but that was not the case eventually. We have no data from New South Wales, which is obviously a big omission. The data was somewhat representative, though, as demonstrated in the first table. We didn't stratify by the population by any factors because the sample was sort of 402 patients. We didn't achieve all of the primary and secondary objectives. However, the data set I think is available for others to analyse. So I think if you have any medical students or anyone who might want to interrogate these data a bit more, I'd be quite happy for someone to do that. And another thing that we wanted to do at the outset, we wanted to calculate the prevalence of risk factors. So you can see this table here from the story paper. They were actually able to find denominators and calculate prevalence of various risk factors. We tried to do that, but we found a lot of the denominators difficult to obtain, particularly for some of the risk factors like hepatitis, etc. And I think the final challenge that we've talked about quite a lot is that there was a heavy administrative burden for the ethical approvals. This has been documented by other authors, of course. And just to show you, we needed 7 ethics approvals for the 4 jurisdictions. When we decided to sort of complete the study, we were discussing with Queensland, and we would have needed 8 in Queensland, 8 site-specific approvals. And then New South Wales, we would have needed many more. And this has been well documented that this is a sort of an ongoing issue in Australia for Australian researchers, this kind of heavy ethical approval burden. And there are quite different requirements, I think. So, for example, in South Australia, they approved it as an audit, whereas other ethical committees wanted a full ethics application. We had quite a lot of back and forth about the waiver of consent as well. Yep. Sorry?
Just 1 minute, sorry.
Yeah, sure. Yeah, I'm about to finish. Yeah. So just to conclude, I guess, I think that collecting detailed information on risk factors probably is quite important in various settings, including low incidence countries such as Australia. We could see that 12% of patients do report some adverse economic or social consequences, which is probably not well documented. And based on this study, we recommend that the risk factor variables that are collected in NNDSS are reassessed. And of course, one of those variables might be diabetes, where 10% of the population had diabetes. And I think these kinds of analysis do provide an opportunity to focus TB elimination efforts in low incidence settings such as Australia. And finally, I'd just like to acknowledge the people who have been involved, including the medical students who did the analyses, the ANU supervisors, the investigators, I guess many of which are in the room or online, ACTnet, including Greg and Elise, and the CRE for the seed funding. Thank you.
Thanks, Kerri. Time for one question, and Kerri's also joining us tomorrow. Got one from online, I think.
We do. This is from Maru Castellanos, sorry about that, who's up at JCU, who asks, did you see any difference regarding the TB completion rate or any of the risk factors according to state and region?
Yeah, we didn't do all those sub-analyses, unfortunately. I mean, we only had 400 patients, so we didn't do those analyses, so it's hard to tell. I'd be quite happy though for someone to look at the data set in a bit more detail and do that, but we didn't do those for this particular project.
Great, thanks very much, Kerri, and we look forward to hearing you talk tomorrow. And some of the issues you raised about ethics, we might bring it over into the last session of the day about how we implement sort of collaborations and so forth.
Yep.
So,